Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population. In today's podcast, Dr. Everett Magann joins us to discuss prophylactic transfusion during pregnancy for women with sickle cell disease. Dr. Magann is the corresponding author of an article appearing in the April 2021 issue of the Southern Medical Journal that addresses this topic. Thank you for being here today.
Thank you very much, and thanks for inviting me.
Let's get started with a question regarding your review article on transfusions during pregnancy for women with sickle cell disease. You made a clear differentiation between emergent transfusions and prophylactic transfusions. Can you please explain the difference between these two types of transfusions in pregnant women with sickle cell disease?
An emergent blood transfusion would be a transfusion that is given only when indicated for medical or obstetrical complications of pregnancy. Some examples of this would be a transfusion that would be done for sickle cell complications of pregnancy and would include maternal anemia, sickle cell crisis, or perhaps pain that didn't respond to conservative measures. A prophylactic transfusion are transfusions that are given at intervals during pregnancy when no or fewer symptoms to improve the oxygen carrying capacity of the blood by increasing the hemoglobin concentration and lowering the hemoglobin S in the blood. Oftentimes, most people would try to decrease this to less than 30% and keep that level, the hemoglobin S, below that level, below that threshold for the remainder of the pregnancy.
Thank you, Dr. Magann. This is Rich Holt. We noted that you were previously a faculty member in obstetrics and gynecology down under at the University of Western Australia in the early 2000s. Did you note any differences in the prevalence of sickle cell disease in pregnant women in Australia compared to the US, as well as a difference in treatment protocols with respect to transfusions in these women during pregnancy?
The big difference was actually probably the number that we had to treat, because the percentage of Aboriginals in Australia is approximately 3% of their 25 million people, versus in the United States, the number of people from African heritage would be approximately 13% of 330 million people. So just the mere numbers of patients. I didn't really see any significant difference in the treatments down there down under, because they were basically treated the same as we're treating them now in the US, and that's using the emergent blood transfusion therapy protocols on those women. Kind of as a side note, you may find very interesting, the one thing I did find about Aboriginal women is that they are very difficult to treat from the standpoint of diabetes. It was many women that we would have over 200 units of insulin per day.
I was just interested on a follow-up question, Dr. Magann, if there has been any concerns, even in the last 20 years, regarding viral infections, viral particles in transfusions that might put these ladies at higher risk when they need the transfusion.
Yes, sir, and that's been one of the major reasons that we went away from prophylactic transfusions and went to emergent, is because of the emergence of HIV in the 1980s. And that's really when you saw the universities that were using prophylactic transfusions really go to more emergent. Prior to that time, probably greater than 50% of the universities actually were using prophylactic transfusions.
Dr. Magann, how did you become interested in the timing of transfusions in pregnant women with sickle cell disease?
I really became interested through my mentor, John Marson, when I was MFM fellow at the University of Mississippi in Jackson. Dr. Marson had trained in Memphis and become interested in the treatment of sickle cell disease. He related to me that in the 1960s and prior to that point in time, that the maternal mortality with sickle cell disease was high and the perinatal mortality was 50 to 60%. But that began decreasing in the 1970s, and those rates have dropped dramatically from a maternal mortality of 4% down to 2%, and the perinatal mortality decreased from 50 to 60 down to 20 to 25%. Now, a lot of this was due to more prompt attention to the treatment of infections, more intense hematologic surveillance, and the great strides we've made by the neonatologists in our newborn intensive care units. But at this point in time, most of the universities were doing prophylactic transfusions versus the emergence. And as the question which you just asked me a few minutes ago, this had progressed to the point that in the early 1980s, they had actually convinced the NIH that they need to do a funded trial to determine which would be better, the emergent or the prophylactic treatment. But then this was the time that the HIV came on the scene. The NIH rescinded the funding for the trial because of the great concerns of HIV and bloodborne infections, and the trial certainly was never done. John then approached me. We had worked on a number of research projects since that point in time, and he approached me about re-looking and re-evaluating this. And we did our first paper on sickle cell, which actually we published with you all in 2016, where we actually looked at women who, we looked at actually 2 epochs in time. These were all women who had the emergent type of transfusions. And we looked at a group that was delivered between 1979 and 2003. We got that from the literature, 5 trials, about 279 women. And then we compared them with the more recent deliveries between 2005 and 2016 at the University of Mississippi Medical Center, the University of Arkansas for Medical Sciences, and the University of Missouri Medical Center in Kansas City. We had 150 women. And it was interesting to us that the findings were only really minor differences between the 2 groups. The overall maternal and perinatal outcomes really hadn't changed in the past 50 years. So it was from that we went ahead and we progressed on to our second trial, which is the basis of this discussion today.
Well, thank you for that information. I read your article, which in the pre-publication phase is going to be published next month in the Southern Medical Journal. You indicated there that you did not perform a traditional meta-analysis of the literature search in which treatment effects are combined from multiple studies. Can you please summarize for us how your data were analyzed and why you chose the method you utilized?
Well, we certainly couldn't do a traditional meta-analysis because we couldn't combine all the studies comparing emergent versus prophylactic transfusions because there's really only one study in the literature that actually did that. Most of the studies would either report either prophylactic or they would report the emergent type of transfusions. Let me say here that probably the most important thing that you can possibly have, and I've seen this throughout my career, is have the support of a good statistician, which you involve from the very onset, and that you go to them with questions like this. He suggested to us that we use linear mixed effects modeling for this because we're unable to analyze all the data. We examined the associations between the types of blood transfusions, the emergent versus prophylactic, with each maternal and infant outcome. In this study, we used blood transfusion as a fixed effect and maternal and perinatal outcomes as the random effects. This type of modeling is especially suited to a study like ours, where interventions from each study differ in ways that could affect the results of the study. Linear mixed effects overcomes the limitations of not having the comparison groups in each study, so that a meaningful comparison can be made between the maternal and neonatal outcomes between prophylactic and emergent transfusions.
Dr. Magann, what were the major observations you gleaned from your literature search and analysis of the data regarding the timing of these blood transfusions in pregnant women with sickle cell disease?
We did a very comprehensive literature search to begin by our research librarian. We identified 254 abstracts, which Dr. Morrison and I then reviewed. And of those, we identified 21 studies, which were the basis of this review in this paper. In those, we evaluated, we found, and we did this in action, the first study too, that we've identified 10 maternal and perinatal outcomes: preterm labor, preeclampsia, pneumonia, pyelonephritis, pain crisis, fetal growth restriction, cesarean delivery, maternal mortality, neonatal death, and perinatal death. After the analysis was done with the linear mixed effects modeling, we found 4 significant outcomes between the groups. The risk of preterm birth, pneumonia, pain crisis, and perinatal death were greater in the emergent group compared to the prophylactic group. There were no other differences between the groups. One of the other studies which we identified was a study by Malinsky, and this was actually published in Blood in 2015. And they also showed a reduction, but they alluded to, as we have, that because of the construct of the studies and because of the small number of studies and sample sizes, and because there is the increased potential of bias, that they also found that prophylactic was more beneficial from the standpoint of maternal mortality, vaso-occlusive episodes, preterm birth, pulmonary complications, and neonatal death.
Thank you, Dr. Magann. This next question is a two-part one. The first is, what are the major risk-benefit considerations that you discuss with the patients and family for any type of transfusion in pregnant women with sickle cell disease? And then an adjuvant question, what are the major etiologies that present themselves in these ladies for requiring a transfusion?
The major risk of a transfusion would be alloimmunization would be one. And I did see this quite a bit when I was in Mississippi. This was in the 90s, and we were using prophylactic transfusions there. And that was alloimmunization. And what we would see is we would see women, and we would cross-match them, and we would transfuse them, and we would do this serially throughout the pregnancy, trying to keep that hemoglobin S level below 30%. And we found out that a lot of them, by the end of the pregnancy, or certainly if they've had multiple transfusions before, that it then became very, very difficult to be able to transfuse them, mainly from the standpoint of trying to get blood that you could cross-match them with. So that is one of the problems that you have. Other problems are, as we've already talked about, the bloodborne infections, hepatitis and AIDS. Although our blood supply now is probably safer than it's ever been. And also because of the shortened lifespan of the sickle cells and sickle cell disease, we can get in a problem with increased iron stores in the mother. And the second part of your question, the major reasons to do a transfusion would be, as we discussed before, would be if we were using the emergent therapy, would be the anemia crisis, the crisis that was painful, that didn't respond to conservative therapy. In the other group, it would be using those transfusions to try and keep that, try to make sure that the oxygen carrying capacity of the blood was at a level where they wouldn't have as many painful crises. And so that was, again, trying to keep the hemoglobin up so they're not anemic, and also making sure the hemoglobin S was at low levels.
What is the current status of prophylactic transfusion therapy for women with sickle cell disease in the U.S.?
It's a study which needs to be done. It's a study just waiting for to rise to the priority list, perhaps of the NIH and perhaps of Society of Maternal Fetal Medicine, for them to undertake this. Because I think until we have some other type of maybe gene therapy to help these women, I believe that we'll never have the true answer of whether prophylactic is better than emergent. And until we have that, at least these studies would suggest that prophylactic is better, but we're never going to do that until we have a prospective trial that will confirm it.
Dr. Magann, you were obviously very active in the American College of Obstetrics and Gynecology. You're an editor of the Journal of Maternal Fetal and Neonatal Medicine, associate editor-in-chief of the International Journal of Women's Health. These very important positions put you at the forefront of understanding the current status of so many therapeutic interventions in maternal health, and you had the special interest, of course, in sickle cell. What further advice might you recommend for your colleagues in the specialty of OBGYN regarding the important issue of blood transfusion in these patients?
Again, I think we're probably just going to have to continue with our emergent transfusions. I think that's pretty much our standard of care that we're doing here, and certainly being done, to my knowledge, worldwide. And I think that we will continue doing that, even though some studies suggest that maybe prophylactic is better until we get that prospective trial, unfortunately.
And one last aspect of that question that just came to my mind. I would gather that your pregnant women with sickle cell disease may also have very similar incidences or rates of hemorrhage in the course of delivery. And is there any other consideration besides the emergent therapy for these women with that particular disease?
Well, again, I think you might have a little lower threshold of transfusing them to keep their hemoglobin levels up, so that, I mean, we seem to think that hemoglobin 7 seems to be at least a good number to try to keep them above. We know that giving them perhaps a little bit extra blood, kind of between prophylactic and emergent type therapy, to keep their hemoglobin up. We know there's no doubt that it does reduce the number of painful crises. So that might be kind of a halfway measure or an intermediate that one could do. Maybe keep them a little higher than you would otherwise.
Dr. Magann, this has been such an informative conversation, and we really appreciate your spending some time with us today discussing this. Do you have any additional comments or thoughts you would like to share with our listeners?
Again, I think if the question comes up and you're listening to this podcast and you're in a situation where perhaps you can talk with, influence other people, perhaps we can influence decision makers at the SMFM or probably our NIH to maybe at least re-examine this article along with other articles to see if maybe this is a reasonable thing that we ought to be doing for these women.
Thank you very much. Dr. Holt, do you have any final questions or thoughts you would like to share?
No, I do appreciate being a part of this podcast with Dr. Magann. Dr. Magann has been a very strong supporter in all the ways for the Southern Medical Journal, and has a great reputation as a medical journalist, researcher, and clinician. So we thank you for your participation.
Thank you, sir.